started. My name is Sui Ng. I'm the long-term care nurse educator. Let me introduce some of our program planners. Sandra Young, you probably met her at registration. She's one of our nurse educators at Audiel Murphy. Another program planner is Pat Walters. She's there in the back. Pat? Yeah. She's our nurse educator here at Audi and at Kerrville. Another sponsor that we have is Greg Thompson. He's there in the back. He has his wound care products from Medline, and they're the sponsor of this program. And if you haven't already, make sure that you put your nursing license number in order to get your certificate at the end of the class. He has a table in the back, and he has some goodies there, so make sure you stop by and see him and check it out. Jill Dickerson is our new wound care nurse, and she has several products that we have here at the VA that you can check out there in the back too. Marc Johnson, he's from Geriatric Education Center. He's here in the front. He's our AV specialist, and he's going to be taping this program.
Keep them all straight. So I say the best way to learn how to pick a dressing is to learn categories. All you need to know is, I need a foam, I need an alginate, I need a gel, I need a, whatever. I need a collagen, I need some kind of debriding ointment. That's all you need to know, and then you go select whatever you happen to have available, whichever foam you have available, whichever alginate you have available. You don't need to special order a specific brand name, okay? So that's how we've designed this section here. But before we get there, we're going to talk a little bit about what we're expecting to see when we're trying to help a patient heal their wounds. Okay? We want to get these wounds closed as fast as possible, because studies show us the longer a wound stays open, the lower its chances ever go of healing. Also, one of the things that literature will show us, and I think this is one of the things we often overlook, the longer a wound stays open, the higher its chances of developing a malignancy go. And I'm a firm believer that a lot of these, what we think are venous ulcers and other types of leg ulcers out there that have been open for 2, 3, 4 years and won't heal, are not healing because we're not doing good wound care. They're not healing because they're cancer. They've already turned malignant. And you can't heal a cancer with good wound care. And if we would do more biopsies, like we talked about in the earlier session, we might be able to find out what's really going on, and we may be able to help these patients. But not if we don't know, not if we're treating the wrong thing. Okay? We also need to focus on reducing pain, improving quality of life, preventing complications, and preventing recurrence, because the recurrence rate on a venous ulcer is like 70 to 90%. Diabetic ulcers are about as high, about 70%. I'm a firm believer in the KISS method of wound care. Anybody know what that is? And it's not that. That's exactly it. Keep it simple, stupid. Because the more complex and complicated you make a dressing change order, the less likely you are to get compliance and to get consistency with the wound care. So your orders, your dressing change orders need to be this simple. Clean it, fill it, cover it, get out of the way. Do that as little as possible. Don't stick your hands in there and fiddle with it. Okay? Do a good cleaning. Select a good dressing that's going to give you good wear time and manage the local wound environment, that's going to keep an optimally moist wound environment. And then pick a cover dressing if you need it, that's going to stay in place and keep that wound warm and protected and insulated. And then get out of the way and let the body do what it knows how to do, because it knows what it's doing. It does just fine if we leave it alone. And then we need to manage costs, because everything nowadays is about money, isn't it? And can we get good outcomes without spending a lot of money? Absolutely we can. And it doesn't mean we're giving poor quality care. It just means we're being responsible with what we have to work with. Because do you think this is happening? Yes. Absolutely. Regardless of the payer source, even if you're in the VA system, they control things, don't they? And quality improvement programs out there have been put in place to help us do more with less and improve outcomes. And you know, the sad thing is that they have to hit us in the pocketbook to get us to change our practice, to get us to think outside of the box and find new ways to do things better for less money to get good outcomes. The sad thing is we're not going to change until you tell us you're not going to pay us for it anymore. That's what's sad. Formulary management is a great way to control costs. Tailor your guidelines, your protocols around the formulary. Formularies help us standardize things. So instead of having 5 different alginates and 6 different foam dressings and 3 or 4 different gels, you pick one of each. Because really, I don't need 5 different types of alginate to treat my wounds. I just need an alginate. Just give me one. They're all close enough that I can do the same thing with one that I could do with another. Same way with the foam. This cuts down on the confusion. It eliminates waste. It gives you consistency, and it keeps everybody going down the same road with the same goals in mind, doing things the same way, and you ultimately achieve better outcomes as a result. You also achieve better patient satisfaction and better nurse satisfaction because we're not so confused all the time. We're not always sitting there scratching our head thinking, what am I going to do now? And we go into the supply room or into the Pyxis and we look at all these dressings and we go, oh my gosh, I don't even know where to start. You know, it's simplified for you. And patients like it because every nurse is doing things the same way. You know, there's nothing worse than one nurse coming in there and saying, oh, this is how I think it needs to be done and I'm going to do it this way. And then the next nurse comes in and says, no, she didn't know what she's talking about. This is the way we need to do it. Y'all see that happening? Yeah, and then the patient doesn't know who they can trust. They don't know what's really the right idea. Then they eventually figure out that nobody knows what they're doing. And we're just using them as a guinea pig. And we're just trying this and trying that and trying this and nothing's working. You know, we talked about the fact that all wounds are contaminated. And so, you know, national standard guidelines for treatment of pressure ulcers will tell us that clean dressings and clean technique are appropriate for managing pressure ulcers. Because when it comes right down to it, there's no such thing as a sterile wound. So how in creation can you do a sterile dressing change when you're dealing with a dirty wound? You can start out with sterile dressings. They're not going to be sterile very long. And outside of the OR, it's really hard to maintain sterile technique in a sterile field. And it's not necessary. Now, clean technique, let me clarify, does not mean poor technique. Clean technique is a very stringent, rigid set of hand washing, hand sanitation, dressing storage, setting up a clean field, preventing cross-contamination, using a no-touch technique so that you don't introduce critters into the wound. It's very rigid. And you know, I went to a long-term care facility last week with a nurse, and they asked me to see this patient. And so I said, okay. And so they brought the patient in, and I looked at her and I said, well, is there anywhere I can wash my hands in here? And she said, oh, yeah, like I hadn't thought about that. And so she took me around to the next room and I washed my hands and I came back in there and she's telling this patient, you know, that I'm going to look at his wound. And I said, well, can I have some gloves? Oh, yeah, let me get them for you. She didn't think of that either. And so then she gave me some gloves and she went ahead and put on some herself, but she didn't bother to wash her hands, of course. And she went ahead and put on some herself and she took this dressing off. And, you know, she's standing there holding this dressing and I'm looking at it. And I said, well, okay, so, you know, let's clean the wound first. And she said, oh yeah, we need to get the cleaner and the gauze are up there in the cabinet. And so I took off my gloves and she looked at me like, what are you doing? And I said, well, I'm not going to go reaching up in there and grabbing stuff. You know, so I took off my gloves, I went over and put some gel in my hands, and she's staring at me like I'm a crazy madman or something. And then I go get this stuff out, and I get everything set out, and then I re-sterilize my hands, and I say, "Can I have some gloves?" "Oh, well, let me just get the box," she said. Well, yeah, that's a good idea, because by the time I was finished, I'd used 10 pairs. And you know what? What baffled me was the fact that she obviously never thought of any of that. And that's how we spread germs, and that's why so many of our people got MRSA. Because we're just spreading it from patient to patient because of our technique. Okay? So, I'm going to give you some principles to help you select a dressing. We're going to use the word wound. Okay? Each one of these letters is going to stand for a question you ask yourself. W stands for, is the wound healing? If it is, you're doing a good job. If it ain't broke, don't fix it. Okay? If it's not, it's probably that dressing's fault, isn't it?
Yeah.
Do you see that anywhere on the list? No. Because dressings don't heal wounds. It's not the dressing's fault if you didn't do your work and identify the true cause and fix it. It's not the dressing's fault if you haven't been watching this wound and haven't addressed the bioburden and killed the bacteria. It's not the dressing's fault if this wound's chronic and it's got excessive levels of proteases in there that are preventing wound healing from occurring. We do have dressings, collagen dressings, that can help us with that though. It's not the dressing's fault that this patient is in chronic pain and you haven't done anything to manage their pain. Okay? Is that wound healing? Is that wound healing? Yeah. You should expect to see progress fairly quickly after initiation of a plan of care. And like I mentioned with that Dakin's example earlier, don't wait a month to realize that things aren't working. You know, you're just wasting time. Our job is to get things closed as quickly as we can. Then ask yourself, do we have an optimal amount of moisture? Or do we have any odor? And it's real simple managing moisture. If it's wet, dry it up. And if it's dry, add moisture. That's pretty simple, right? We know that moist wound healing is a better way to heal than dry wound healing. We've beat that horse to death today, haven't we? And Elvis here is showing us how to balance things, because that's really what wound care is all about, is balance. Moisture balance is where it's at. You get faster healing, less scar tissue formation, less pain, less risk of infection. It's an overall better way to heal. So keep things balanced, okay? Then make sure that the surrounding skin, the peri-wound skin, is staying intact and healthy. You need that skin. Okay? Do everything in your power to protect it, to keep it healthy and intact. Keep it from breaking down from the effects of drainage and moisture that can break the skin down. We got a problem with that? Yeah. So we've obviously exceeded the absorptive capacity of that dressing, haven't we? So here's the question. Is that the wrong dressing? Maybe. Maybe not. Maybe that was the right dressing and we just weren't changing it enough. Or maybe it's the wrong dressing and we need to look for something that can absorb more. Or here's a novel idea. Maybe we just need to add more dressing. You know, I used to get really frustrated. I'd go out and do an eval on a patient, and I'd just write a real simple order. You know, clean this wound, put some apply alginate and cover it with, you know, a composite dressing of some sort. And then the nurse would call me a couple of days later and she'd say, "You're going to have to come do something. This dressing is getting saturated every day." And I'd say, "Well, why?" And I don't know, I'm following your orders, I'm doing what you said. So I'd go out there and, you know, we'd have a 4x4 piece of alginate and the wound might be this big. So I tell the nurse, "Show me how you're doing this." So remember, this dressing is getting saturated every day. So what does that mean? We're not absorbing enough? So she cuts a piece this big of the alginate and sticks it in the wound and puts the rest back in the package. Well, no wonder it's getting saturated. You're using this much of it. Use the whole thing. Fold it up. If you need it to absorb more, put more dressing on there. That's a lot cheaper than me sending a nurse out here every day to change it, because we want to use a little piece all the time. If we got necrotic tissue, we got to get it out of there. We talked about the reasons for that. Now here's a question. Do we need to debride this wound?
No. You gotta check blood flow.
Well, okay, good point. She says we need to check blood flow. Let me give you two different scenarios. That's not wrong. That's not wrong. You show me how I can Doppler his butt, and I'll go along with it. Maybe that's a new invention you can come up with and make yourself a millionaire. Okay, let me give you two different scenarios, and you tell me, okay? This is a 58-year-old man who was in a motor vehicle accident, and he's been in the ICU for a month. During that time, he almost died. He developed this pressure ulcer, but now since then he's been moved out to the floor. He's stabilized. He's getting ready to leave here and go to rehab. He's going to get back on his feet and be healthy again and have an active lifestyle. Do we need to debride that? Absolutely.
Really?
If you want healing to occur, you got to debride that. Now, this is a 78-year-old guy who came in from home. His wife's been taking care of him because he's bedbound. He's in end-stage CHF. He can't get around. He developed this pressure ulcer at home. We're just trying to get him stabilized so we can ship him out to hospice because he's terminal. Do we want to debride that? No. See the difference? You have to ask yourself, what is my goal? Is healing my goal, or is healing maybe not my goal? And that's how you determine, do you need to debride that? Now, we said if it's on the heels, right, we don't ever debride it. Okay? That's not a heel, is it? Obviously, huh? Okay, if there's depth or dead space, we need to pack it, right? Okay, just checking. So let's ask ourselves those questions. Is this wound healing? Doesn't look like it, does it? Does it have an optimal amount of moisture? Looks a little dry, doesn't it? Do we have, understand the peri-wound? Looks pretty good, doesn't it? We have necrotic tissue? Yeah, a little bit. Do we have depth or dead space?
Yes.
Okay, so when it comes to selecting a dressing, we need a dressing that's going to help us donate moisture, because this is dry. We need a dressing that's going to keep the wound bed moist, but not make the peri-wound skin moist, right? Keep the surrounding skin dry. We need to pick a dressing that's going to help us get some debridement, and that could just be, we could just say, well, we're going to let it autolytically debride and squirt some hydrogel or something in there and just hydrate it and let it autolytically debride. We could pick an enzymatic debrider. We could say, well, I really want to get this debrided first. That's going to be my focus. So we're going to use an enzymatic debrider, and then we're going to use something to fill that dead space, right? It just depends on what your goal is, okay? What your priority is to help you determine what kind of dressing you need. So when you're trying to decide, make sure you know what your goals are, and then pick a dressing that will help you achieve those goals. So next time you feel like you're walking around in a sea of confusion and you open your treatment drawer and it looks like this and you feel like this, just stop and take a big deep breath and ask yourself, okay, what are my goals? What's wrong with this wound? Do I need to add moisture? Do I need to absorb moisture? Do I need to treat the peri-wound skin? Do I need to debride this wound? Do I need to fill this dead space, or is it flat? And then pick a dressing to help you do that. It's not that difficult. Okay? We're going to talk about categories. We're going to talk about antimicrobials first. Because all of the dressings we're going to talk about after this, all of our regular dressings, are going to come in some kind of antimicrobial form. Most of them will come with or without silver. Okay, silver is the most commonly used antimicrobial. We've been using it for thousands, if not hundreds, if not thousands of years. Okay, and still to this day, no resistance noted in people. You can see everybody makes their own brand. It comes in all shapes, sizes, and forms. Powders, gels, transparent dressings, hydrogels, collagens, alginates, foams. Anything you want with silver in it, you can get it. You can kill bugs regardless of what you're doing with the wound. Okay? Now, there's some questions you need to ask when you pick a silver dressing. You need to know what kind of silver is in that dressing because they function differently. Some dressings contain ionic silver that's activated from moisture in the air or in the wound. Some dressings contain metallic silver that have to be pre-moistened to activate them, to cause a chemical reaction. Sterile water. You have to moisten the dressing, and that releases silver ions into the wound bed. Now the question with that always is, what happens if the dressing dries out? Are you getting silver release? No. So you need to know that. That's something important for you to know. So you make sure you use that dressing correctly and you get the performance you want out of it. Okay? Silver, like we said, we don't have resistance problems because unlike antibiotics, silver does not target one specific area of the cell. It doesn't attack just one area. It is like a scatter gun. It hits all over the place. Sometimes it interrupts RNA transcription or DNA synthesis or cell wall transport or membrane function or whatever the case may be. And to this date, bacteria have not been able to figure out what it's doing so it can mount a resistance to it. So that's why it works so well. Now, here's an example of using an antimicrobial. This is a superficial wound, right? So this wound healing, no. It's an optimal amount of moisture. It was draining really heavily. This is poison ivy, by the way. This patient had been on antibiotics and steroids for a month. We still had this weepy skin condition. We knew it was heavily contaminated because, like I said, when it's draining a lot, you've got bacteria there. So our goal here was to pick a dressing that will cover a flat surface, will absorb a lot of exudate, and will kill surface bacteria. So we picked a silver alginate. That's met all of our goals. We expected it to work, and this is what we had a week later. You know your goals, pick a dressing that helps you accomplish your goals. This is a case study using a silver hydrogel sheet. And really what it shows you here is we get bacterial load control, we get autolytic debridement, we ultimately start promoting granulation tissue formation, we get contraction, and it ultimately went on to epithelialize. Now, silver is not the only antimicrobial that we have available. There are some very good cadexamer iodine products out there. It's sustained release iodine that works very well, safe, non-toxic. It's not like betadine. Okay? CHG, chlorhexidine gluconate, is the antimicrobial we find in biopatches. Polyhexamethylene biguanide is the antimicrobial we most commonly see in our if you're using negative pressure, gauze-based negative pressure wound therapy systems. This is the antimicrobial gauze. That's what the antimicrobial is in that. Now, I skipped over this product on purpose because I want to point out that just because a product is in the antimicrobial category does not mean it kills bugs. There's a difference between products that are bactericidal and bacteriostatic. What does cidal mean? It kills. What does static mean? Yeah, it just kind of maintains the status quo, right? Keeps everything in stasis. Okay? So, you need to know the difference between antimicrobial products that are bactericidal and those that are bacteriostatic. Because if you use a bacteriostatic product in a wound that you need to kill bugs, is it going to happen? No.
Is that the CHG?
That's the hydrophthora This gentian violet methylene blue is bacteriostatic. Okay? It doesn't actively kill bugs. That doesn't mean it's bad. That just means, you have to use it appropriately. If I have a wound that I want to maintain the status quo and I don't want these bugs to get out of hand, bacteriostatic product works very well. We're going to talk about a glycerin-based hydrogel sheet here in a little bit when we get to the hydrogels, and it is bacteriostatic and fungostatic. That means it inhibits bacterial and fungal growth. That's great to know. I might need to use that. Okay? Collagen dressings are what we call an active wound dressing because they're actively involved in the wound. These products are designed, if I can get this to change, everybody makes their own. They come with silver, without silver, so you can address enzyme imbalances and bacterial load imbalances in the wound. And these are designed to bind those bad enzymes. Remember at the first of the program we talked about chronic wounds and they have these proteases, these what we call MMPs, matrix metalloproteases, these bad enzymes that in the inflammatory phase of wound healing have a real important purpose. Their job is to come in and break down collagen and tissue and help the body clean the wound bed up and prepare it to move into the proliferative phase to close this wound. But what happens with these wounds that stay chronic and stay open is these enzymes essentially get out of control. We get too many of them in the wound bed, and they're eating up the collagen as fast as your body can lay it down. So we have these wounds that are healing really nice, and all of a sudden they just stall. They just stop. Y'all ever seen that? Wound is healing really good, and all of a sudden just stops. It won't go anywhere. And you wonder, what happened? Well, it could be bacteria. It could be you got too much bacteria in there and that stopped it. Or it could be an enzyme imbalance. A lot of times it's both.
So do you see a lot of drainage with that as well?
You may not see as much drainage if it's just an enzyme imbalance as you would if it's bacteria. But it can be both. And that's why your collagen dressings will come with silver so you can treat both at the same time. So this is one of those dressings we say, we use this to give these wounds a kickstart, these stalled wounds. Because what they do is they serve as a sacrificial lamb. These MMPs want to chew up collagen, let's give them collagen. But let's let them chew it up in the dressing instead of chewing up the collagen that your body's laying down. Now, different collagen dressings work differently. They use different types of collagen and they're processed differently. So what you want to look for are collagens that are what we call really highly native, meaning the collagen bundles look more like the natural human collagen. That's going to make them more attractive for those enzymes, okay? And then there are some collagens that are better at binding MMPs than other, and you need to ask how much collagen is in this dressing. Because some collagen dressings you get are only 50% collagen. Yet you're paying these high prices for a collagen dressing, and you're getting half of what you paid for. Okay? You need to know that. This is just a case study of using a collagen dressing to take a chronic stalled wound. Now these collagen dressings, you know, when you put this in a wound, those enzymes are going to eat it. They're going to digest it. When you go back to change that dressing, guess what's happened to that dressing? It's gone. It's gone. It's chewed up. It's eaten away. It's digested. That's a good thing. Okay? If you go back and look and there's still collagen there, it's still got time. It's still working in there. The enzymes are still working on it. Okay? Growth factors. Very good for specific types of wounds. Most notably full thickness diabetic foot ulcers. Interesting thing to note on this type of technology, on this one product specifically, is that in 2008 it received a black box warning from the FDA because of a study that came out that showed a real high correlation between patients who used 3 or more tubes of this product and those that developed cancer. Now they didn't say this product caused cancer, but what they said was, whoa, back up here a minute. There's too big of a comparison here of those who used it and got cancer than with those that didn't. So we need to do some more research, and in the meantime you better take a real close hard look at do the benefits outweigh the possible risk when you use this. Okay? Bioengineered skin substitutes and extracellular matrix dressings are the big guns. So I usually will start a patient, you know, with just standard wound care. If nothing's happening, you know, I'm going to address bacteria. I'm going to pull out my collagen to address enzyme imbalances. If I'm still not getting a good reaction from the wound, then it's time to pull out the big guns. And these products give you high-grade collagens, high-grade proteins, growth factors released into the wound to really give these wounds a kick in the pants and try to move them on towards closure as quickly as possible. Very beneficial tool to have in our bag. Polyacrylate dressings we talked about in the previous session as a form of debridement. In this case study here we saw this dressing was used from the time it looked like this, to this, to this, all the way to healing. And I don't have it all the way to closure, but I got it all the way to here. And it did go on to full closure with one dressing. Very, very good use. And not one, they didn't use one dressing for 48 days. One type of dressing, I should say, okay?
How long do that dressing until it closes and completely closes?
Yep, they used it all the way until it completely epithelialized. It is good for debridement. Here's a case study. One day, debrided this leg ulcer that's a result of pyoderma gangrenosum. Very painful, inflammatory condition. They use this dressing because it's non-adherent. It safely, painlessly debrided this wound and works very well. It doesn't damage the surrounding skin because it's only interested in large protein molecules. So it's only active right there over the wound site. Other modalities that we use in our wound management, a lot of these are therapy modalities, and you guys holler out if y'all use any of these. You already told me y'all use or don't use pulse lavage. You do, some of you. Okay. Ultrasound, y'all use that in wound management? I don't see much of that. Hyperbarics, now that's not necessarily therapy, but that is a great resource to have, especially if you've got necrotizing fasciitis, osteomyelitis, gangrene, you're trying to do limb salvage, you're trying to keep this person from losing this toe or this foot or this leg. It has a great place in wound management. And, you know, although somebody was telling me, who was that told me earlier that some doctor believes it's hocus pocus? Yeah. And, you know, some people don't believe it works. Some people do believe it works. And so I think it definitely has a place. I think it can really help in specific circumstances. I wouldn't throw everybody in a chamber, but definitely if nothing else is working, it can surely help. E-stem, I've seen some really good results in wound management with combining E-stem with my wound management. Any of you guys ever use E-stem? Any of my therapists? Yeah? Infrared light, that's anodyne. Anybody still use anodyne? I haven't seen that used in a few years. Diathermy, I've never seen that used. I've seen mist therapy used a lot in wound clinics. See some pretty good results of it. It works pretty well. Negative pressure, you know, is no longer just the KCI vac. And y'all are so close to San Antonio, I don't want to get struck by lightning by saying that, you know, negative pressure is not just the vac anymore. It's this kind of mecca for the vac down here. But last time I checked, there was 15 or 16 other negative pressure wound therapy systems out there on the market. And, you know, I don't go into details when I cover this because, honestly, I don't know what they all are. I can't keep up with all of them. There's a new one every week. All I can tell you is they're great for helping increase and promote granulation, blood flow, removing drainage from these heavily exudating wounds. They're good at helping promote contraction, especially on these large wounds. You know, picking one brand over another is just like picking any other kind of dressing. You know, sometimes you don't have a choice. You choose whatever your facility is going to keep on hand. Sometimes they make the choice for you. Other times you just choose it based on the wound characteristics. What are the features that you need? That's going to determine which one you use. Oh, sorry. First advanced wound care dressing that came on the market were transparent films. And was anybody around when OpSat came out? And then Tegaderm? You remember what a huge discovery that was? It was like, oh my gosh, you know, where have we been? Now we can heal anything. And so we slapped it on skin tears, and we slapped it on pressure ulcers, and we slapped it on everything. And sometimes I think we just wallpapered our patient in it just to make sure nothing happened, you know. And we thought it was great. And don't you wish you were the person that saw nurses bringing saran wrap in from their kitchen and putting it on their patients and said, I think I can cut that little pieces and put some adhesive on the back and make me a fortune. Because that's where they got the idea. Because we're bringing stuff from our kitchen all the time and putting it on our patients. It works so well at home. We found out, though, however, it doesn't absorb anything, does it? So it wasn't great on every wound. It worked on most wounds, a lot of wounds, especially dry to minimally draining wounds. It gives you great autolytic debridement. We used to use them all the time just to autolytically debride wounds because they kept a moist wound environment. Gives you good tissue growth. They're very waterproof. They give you a good barrier against bacteria. I like to use them as secondary dressings, but you have to remember they're very, very adhesive. There was a time back in the day that this was considered standard of care for treatment of skin tears. But those days are gone. We have better things now. And the principles are really pretty logical if you think about it. If a patient has a skin tear, why did they have that skin tear? Because they have really fragile skin. And the last thing you want to put on really fragile skin is a very aggressive adhesive, because you eventually have to take that off, don't you? And you know, back in the day when this was standard of care, if you were the one that found that skin tear, you had it made. Because you initiated that treatment and you slapped that tegaderm on there, and then the next time the dressing change came around, you ran and hid. And then the next nurse who had to go take that off was sitting there cussing you, wasn't she? Because now she got to figure out how to get this off without tearing the rest of this skin off of here. And so we've kind of figured out that there's better ways to manage skin tears than that without causing further damage. And you know, really what a transparent dressing does, you know, we like to see that bubble of fluid right over the wound bed. And you know what we're mimicking when we use these? We're creating an artificial blister. We're creating the way the body already is designed to heal. That's how it works. It makes a blister. Keeps everything nice and warm and moist. We're just making an artificial one. Pretty cool way to do it too. Here just shows you a case study using a transparent film for autolytic debridement. This is what I like to use them for. You know, transparent dressings even come on rolls now. You can buy them on a roll like tape. And so you can put your primary dressing down, and then you can just seal it up with this, make it waterproof and bacteria proof. Also remember, using transparent dressings decreases shear and friction. So in this area here that's exposed to contamination and moisture and friction, we get a lot of benefits out of putting that on this wound as a secondary dressing. Then Duoderm came out, and now every hydrocolloid is a Duoderm, right? Just like every soda is a Coke. And you know what? Back in I remember this. Y'all remember this? We had Duoderms and we were putting it on everything. It was like, oh no, you know, this is just candy. Let's just throw it everywhere. You know, it's Halloween all year round, and we'll just put it on everything. And you'd go in and your patient would have a sore on their butt. And you'd go in and slap a Duoderm on their butt, and then you come back and make your next round, and you'd say, honey, let me check your dressing. And you pull out the blankets and you'd go, well, where'd it go? You know, and it's rolled up in the blankets or in the sheet, or it's rolled up on the side of their butt. It looks like a big piece of snot or something there, you know. It was gross, and we couldn't get them to stick anywhere, except where we didn't want them to stick, huh? Well, we've come a long way in hydrocolloids, believe me. We're on our 6th or 7th generation of hydrocolloid technology. We now get as much absorption out of a thin hydrocolloid as we used to get out of a thick one, and they no longer turn into that ooey gooey runny mess. You remember you used to pull them off of there and it was just melted and nasty and it stunk? Stunk like something died in there. Well, now they don't do that anymore. They're very good in dry to moderately draining wounds, so they'll absorb a little bit. They're very waterproof and bacteria proof, but again, they're very adhesive if you know how to use them. Good wear time, 7 days. If you have to change them more than 3 times a week, it's a little too costly to do that. It's not real good. Okay? Here's an example of those old style duoderms. Here's the new style hydrocolloids. They don't melt into that. This is what we used to call high gelling or high residue hydrocolloids. They were designed to do that, to melt and liquefy to create a moist wound environment there. That's what they were designed to do. But now we've designed them where they absorb without making that ooey gooey mess. And we've even got so fancy that we figured out how to incorporate cyclodextrins in our hydrocolloids. Anybody know what cyclodextrins are? That's the active ingredient in Febreze. It locks away odors. Now we don't have bayberry scented hydrocolloids or something like that. And we haven't got that fancy yet. Not saying we won't, but we have been able to address the problems. It doesn't melt and it doesn't stink as bad. Pretty good advancements. Now I know a lot of people that say hydrocolloids are old technology. We've moved past them. I don't use them anymore. I know some people that still rely on hydrocolloids real heavily. How about you guys? Anybody use hydrocolloids? A few? I still think they're good. I mean, I have to have the right kind of wound, and I think they definitely still have a place in our bag for helping us manage these wounds. Good for debridement. You just put it on there and let it autolytically debride. Again, know what your dressing is designed to do. Don't pull the dressing off. Don't pull the dressing off and see this ooey gooey mess and start screaming and think you have an infection. So take the dressing off, throw it away, clean your wound, and then do your assessment because it may be completely resurfaced. Okay? Now this is an extravasation injury. This is back in the day when we were putting duoderms on everything, but it worked very well. You know, we got a lot of tissue necrosis here. They put a hydrocolloid over it. 10 days later, that's what we had. That's a good use of a hydrocolloid. They're really good on these wounds that don't have a lot of depth, that don't drain a whole lot. So it's a good dressing to put on there. Shouldn't have to do a lot of picture framing anymore. Our old ones, you remember they had those really thick edges and they stuck on everything. Well, now they're designed with tapered edges. So they're really tapered and they're really low profile and they don't catch and roll up as bad as they used to. Hydrogels help us manage these dry wounds. So if you have a dry wound, you need to add moisture. Best way to do that is with a hydrogel. Now they come in different forms. The amorphous forms mean that without shape. These are your gels that come in tubes or little single-use applicators. They come with silver, without silver. Okay, if you need to kill bacteria, you're going to pick one with a silver. If you don't, you just pick a regular one. They also come in sheets, in solid sheets. Now, I had an interesting case yesterday at this seminar I taught down in Houston, and this nurse came up to me and she said, "Here's a problem, tell me what to do. I've got a lady with a prolapsed bladder, and it's literally bulging out her vagina. Bubbled out there like a head." She said it looks like a little head there sticking out, and of course no hair on it, but just a head. And she said she sits on it, and she's got an ulcer on it. And how do we put a dressing on that? She said, "We can't figure out what to dress it with." And I said, "Well, you know, first thing I'd probably be doing is trying to look at getting a pessary or something to hold that up inside and not let it just hang out between her legs. But if that's not possible, then what are you going to do? Well, you've got this mucous membrane exposed to air that's getting dried out. It's ulcerating, and she's literally getting a pressure ulcer from sitting on it. So how about trying a hydrogel sheet? It's going to be real soothing and cooling. It's going to keep it moist. It's going to stay intact there. And then put whatever you want over that. And then I said, go get some of those postpartum mesh panties. Pull it up and hold it in place. Keep your dressing in place. You're not going to stick to anything down there, are you? That's a great way. You need to add moisture. You need to keep that tissue hydrated. Hydrogel sheets are great for that. You can also get hydrogel impregnated gauze. So if you have a dry wound with dead space that you need to pack, right? Okay. All right.
Take it back.
That's right, you're not going to pack. Just testing y'all, so make sure, because we're late in the day, and I know everybody's tired, but wake up, we're almost there, okay? Hydrogel sheet, hydrogel impregnated gauze helps you fill that dead space in a dry wound and won't dry out, okay? Hydrogels will absorb some. Hydrogel sheets are a little bit different. If there's a water-based sheet, they primarily just donate moisture. The glycerin-based hydrogel sheets, though, are a little more versatile. They can help keep a dry wound moist, and they can absorb up to 5 times their weight in fluid. They're pretty versatile. They absorb as much or more than a hydrocolloid. So hydrogels are great for dry wounds, give you good autolytic debridement. I know some people that this is the way they debride their wounds. They just go squirt hydrogel in there, cover it up with an occlusive dressing, and let it liquefy everything and autolytically debride. That's a very viable form of debridement. It works. Just add as much moisture as you can. Okay? Good wear time. You don't have to change a hydrogel dressing, but once every 3 days. Glycerin-based hydrogel sheet dressings give you 5-day wear time. And like I mentioned earlier, they're bacteriostatic and fungostatic. Okay? Here's a case study. This lady stepped on a nail or a tack in her house. She was diabetic, didn't have any feeling, didn't know it was there until her foot started turning gangrenous. And so the doctor initially wanted to just do an amputation. She refused. She wanted to save her foot. So he said, okay, well, I've got to at least take that second toe out. So he did a second ray amputation, took that second toe out, split her foot, essentially right down the middle. Okay? Came out post-op, had her in wet to dry dressings. That wasn't working. So then he switched her to betadine soaked gauze. And then that really didn't work. And you see all the tissues dried out here. Everything's dying. All the skin's peeling off here. And finally it was turned over to the wound care nurse, and he basically said, here, you have at it, I'm going to cut it off anyway. So she looked at it and she said, well, what does this obviously need? Moisture, right? We need moisture. We need to hydrate this. So all she did was squirt hydrogel in there and cover it up. Just super hydrated. And here's what we had a couple of weeks later. And then 58 days later, fully closed all the way through, top to bottom. Just with moisture, just with hydrogel. Now, we still have a little bit of a wound here. And as you can see, she did have some perfusion problems. She did eventually lose the tip of that toe. But she saved her foot and she was happy with the outcome. She didn't wind up losing her whole foot. Again, what was the dressing of choice here? Can y'all tell? Betadine. And so now we get all this dry, desiccated tissue. Everything's necrosing and dying here. So we just took hydrogel impregnated gauze, filled that dead space, added moisture. 5 days later, that's what we had. Not rocket science. Here's a glycerin-based hydrogel sheet dressing. This is my dressing of choice for skin tears because it's non-adherent, it's kind of tacky. And it's bacteriostatic, it's fungostatic, it absorbs up to 5 times its weight. I get 5-day wear time out of it, and when I manage a skin tear, I like to get the flap back in place, get everything covered and clean, and then leave it alone for as long as possible. So here's a patient I had a few years ago. This patient was in a car wreck the day before and went to the ER with this big, huge skin tear on his right arm. And instead of trying to do anything with it, they just left all that skin wadded up there and slapped a gauze dressing over it and wrapped it up and sent him home. The home care nurse went the next day to do his visit and found it like that, just saturated and stuck, caked down. Now she called me, and we're about 20 hours after the accident, and this is what I find. This big, hearted, congealed glob of skin here. Now the question is, can we save any of that? And the point I want to make is, even though we're talking about all these fancy dressings that we've come up with, we have never ever created anything anywhere close to the original human skin. The best dressing you can put on a wound is the patient's own skin. So, if at all possible, save it. So I did. Took me a little while. I didn't know if it would work. I didn't know if that skin would be viable. But you want to see how much tissue I saved out of that big wadded up mess that a lot of people would have just taken their scissors and just cut it off? All that skin was there. Now, we talked about how long it takes to regenerate epidermis, especially as we get older. When you have underlying disease processes, he was diabetic, he had CHF. He was not a healthy person. How long was it going to take him to heal that wound? A long, long time. How long does it take him to heal this one? We put a hydrogel sheet dressing over that, and 3 weeks later you couldn't even tell it had happened.
How'd you get it unraveled though? Like,
a lot of saline irrigant, Q-tip applicator sticks, roll it backwards up his arm, and just start unclotting everything. Really gently. It took me about 20 minutes or so to really just scrub the back of that skin flap to get all those clots unstuck. And, of course, by the time we got all that gauze that was stuck on his wound bed, it was pretty well clean. And we had to soak it off, and it was pretty clean. I just had to get that flap clean. And I still didn't know if this would be viable or not because it had been so long. But it did. It stayed alive, stayed healthy. Alginates are designed to help us absorb drainage. They're designed from seaweed technology. They come in sheets, they come in ropes. So if you have a flat wound, if you have a cavity wound, you pick which form you need to dress the wound. They're only good for moderate to heavily draining wounds. Okay? So you don't want to put them on a dry wound. They give you good autolytic debridement. You can get them with silver. They kill bacteria. Okay? Good wear time. Don't ever stick anything down in a hole that you don't think you can get it out. That's just common sense. Okay? If you don't think you can get it out, don't put it in there in the first place. Here's a great wound. This is that paraplegic guy we saw earlier with that epibole. Now we know that's called epibole, right? This is what we did. We used a rope alginate. We used a silver rope alginate, actually, to kill bacteria. And fill it up there, and we covered it with a foam dressing. You combine those really absorptive products, you get longer wear time, and his girlfriend didn't have to change the dressing as often. This is a gentleman with a condition called hidradenitis suppurativa, and he got really big abscesses all around his perirectal area. Now there's his rectum right there. And he had to have these big radical debridements, and this went all the way through his groin up to his pelvic area. Big in size, it just cut big chunks of tissue out. And he came home and we couldn't figure out how we're going to get a dressing to stay there. So we just took rope alginate and laid it in those incised areas, covered them with ABD pads, and got some of those maternity net stocking panties and pulled them up and held his dressing in place. And it worked. Healed up very nicely. Now, looking at a wound like this, let's take a minute and decide what do we want to focus on with this wound. Does this wound look like it's healing? Is it optimal amount of moisture? Is it wet or dry? It looks kind of dry, doesn't it? So what do we need to do? Add moisture. Okay. Do we have good peri-wound skin? So we need to work on protecting that peri-wound skin, don't we? We need to use a sealer or some kind of skin protectant there. We need to, do we have necrotic tissue?
yes.
Yeah. So now we need to decide, is that our primary goal? Do we need to focus on debridement first? Or do we need to focus on adding moisture first? And just get autolytic debridement? That's just a judgment call. So if we want to focus on debridement, what are our options? Y'all tell me, how can we debride this wound? An enzyme, collagenase, yeah, that'll work. Hydrogel, yeah, we could just squirt some hydrogel in there, just super saturate it with moisture, and let it autolytically debride. That would work. What else? Polyacrylate debrider. That would fill that dead space. That would help debride it, right? How about maggots? We could dump some maggots in there, couldn't we? They'd have fun.
But that's not going to moisten it though.
No, but that's going to debride it. So if we decided that debridement was our priority, and that's what we chose to focus on, that would work. Okay? And then once we get it cleaned up, then we're going to work on promoting healing, granulation tissue. We're going to address, bioburden. We're going to keep the wound bed optimally moist. We're going to promote tissue growth. If it's stalled, then we may want to consider using a collagen dressing to kind of give it a kick start to move it towards healing. And if you use a collagen dressing, the collagen just goes right in here in the base of the wound. Now, you don't want to use a collagen dressing on a necrotic wound. That's wasting product. You need to get it cleaned up and prepared before you do that, okay? But when you use a collagen dressing, then you use any dressing, secondary dressing that's appropriate. So if you're putting a collagen dressing on the wound base and the wound is dry, squirt some hydrogel in there. And then cover it up with a dressing that's going to keep that moist. If you're using collagen on a wound that's draining a lot, put some collagen in there and fill the rest up with an alginate. And then maybe cover that with a foam to absorb even more. See how that works? Foam dressings are our most absorptive dressing on the market. Come in all shapes and sizes with and without borders. Only for moderate to heavily draining wounds. Again, good autolytic debridement, good tissue growth, good wear time. You would never want to squirt a hydrogel in a wound and then cover it up with a foam. Why?
The foam would soak it up.
It's just going to suck all the hydrogel out. Right. That's right. Hydrogels are for dry wounds. Foams are for wet wounds. You shouldn't use them together. Okay? You can use them as a primary dressing. This is a great example. That's all they used on these wounds are foam dressings. And they get good tissue growth, autolytic debridement, keeps this wound bed optimally moist, but you can see the surrounding skin is dry. That's what we look for in a moisture retentive dressing. All the way to full closure. Very good use of using a foam dressing. Now, these secondary dressings that we have are what I call our Band-Aid type dressings. They're designed to help make things easy, help with that KISS method. Clean it, fill it, put a cover dressing on it, and go on about your business. So they come either as a composite dressing or a bordered gauze, and the difference is the composite dressings have a waterproof backing, bordered gauze don't. So clean your wound, fill it with a hydrogel or an alginate or whatever you need to fill it with, and then peel the back off and stick this on, and you're done. Like a big Band-Aid type of dressing. Just designed to make it easy. Okay? Remember, you don't have to tape everything in place. We have other ways to keep things secure. Keep your goals of topical therapy in mind. You want these wounds to close as quickly as possible. You want to keep the wound bed moist and the surrounding skin dry. You want to manage dead tissue, get it out of there, whatever your choice of debridement is. Manage infection, eliminate dead space, keep these wounds insulated and warm and cozy so that the cells can function like they know how to do and let the body heal. Okay? If the wounds aren't healing, probably not the dressing, probably something else going on, unless you picked the wrong kind of dressing. You put a foam on a dry wound and it's just sucking all the moisture out, and in our body a dry cell is a dead cell. So if you dry it out, it's not going to heal. Okay? Utilize your resources, your other team members, your doctors, your advanced practitioners, your wound specialists, your therapists, your product manufacturer reps. I used to call my wound care product rep every day. I had his number on speed dial. And I would see patients and I would see this wound and I'd call him and I'd say, okay, here's the dressing I picked. Do you think I chose the right one? And sometimes he'd say, yeah, that's exactly what I would have recommended. Or sometimes he'd say, well, maybe, but if that doesn't work, here's something else you might try. Or I would call him and say, I've been using this and here's what it's doing. It's not really working like I was expecting it to. Give me some options on some other things I can try. And he would. And it helps me use it. Because these guys, their expertise is free. And they want you to have success with their product. They're not going to lie to you and tell you that it does something it doesn't do. They want you to have good outcomes. Okay? So utilize them. They're a great resource. I've utilized them for years. And remember, we have a skincare hotline here at Medline. If you ever need help and you're not sure what to do, you can always call. You'll talk to one of our clinical team members, or always be a certified WOCN. It's 888-701-SKIN. Now, I will warn you, if you dial 800-701-SKIN or something else, you may talk to a skin expert, but probably not the kind you're expecting. And we're not responsible for that, okay? So make sure you dial the right number. You can always email me if you have a question that I can help you with. I'm more than happy to do so. Achieving an optimal moisture level in the wound is a goal in selecting a topical dressing. True or false? An ideal dressing for a moderate to heavily draining wound would be a foam or alginate. True. All right, make sure you check off your objectives. Make sure you write any comments, good, bad, or ugly, that you had about the program. I hope this has been beneficial. This day went by really fast, didn't it? I told you it would. I told you we'd have fun. I thank you for having me down here. I always enjoy coming down to this area. Take this with you. Refer to it often. It's a great resource for you guys. Make sure you turn your evaluations in and drive careful. Yes, ma'am.
Hydrogel dressing, you don't put anything on the outside of it then? So
On,
it's gonna,
on the hydrogel sheet?
yes.
Depends. Now, the glycerin-based hydrogel sheet has a backing on it, so you just have to secure it down. Some of your water-based hydrogel sheets may require a secondary dressing.
Like a film?
Maybe, yeah, that would work. Just something to keep the moisture and keep them from drying out. Silvosorb sheets are going to be good. You're not going to get as much autolytic debridement out of that, and I don't like them so much for cavity wounds. If I was going to do a cavity wound like that and I wanted to get autolytic debridement of the remaining necrotic tissue, the slough that's there, I'd probably put Silvosorb gel in there. That way you get silver release, but you get the hydrating effect of the gel, so you can kill bacteria and moisten things up and maybe get it healed.
Right now the wound is a huge thing now.
Is it
About
draining?
11 by 8, and it has gotten moderate.
Okay.
Moderate to large amounts of drainage.
Okay.
Pinkish on the edges, it has the slough.
Mm-hmm.
So I'm trying to see if there's something that I could put on it to reduce the bioburb.
Yeah,
burden
the
first,
quickest
and get
way.
to maybe something like that.
Yeah, absolutely. That's going to clean it up the quickest. It'll pull all the bacteria out, but now that's a daily dressing change. So that that sometimes people can and can't do that. But that's a great way to clean it up, to hydrate it, to get it to start healing. If we're doing bacteria and we're just focusing on bacteria, the quickest way I've found to cut down the bacterial load is our product we carry called Arglaze powder. And Arturo can show you Arglaze powder. It's a silver powder, and you dust it in there, and it goes all onto the wound tissue, and so it's real aggressive because it goes directly onto the tissue where that bacteria is, and it kills it really quick. And it cuts your drainage down, and it really cuts your surface bacteria down. And then, I'll do that for 3 to 5 days or something, and then look and see what I've got, and then maybe go to a gel or to an alginate or whatever I need to from there. That's the quickest way to get your bacteria under control.
What is the name of that?
Arglaze powder, and it'll be over here. Arglaze. And it comes in a sheet, or it comes in like a transparent dressing or a powder, but you want the powder. Powder's the best thing. I use the powder probably more than any other antimicrobial because it's just so aggressive and helps get a handle on it. And where do you live? You live here?
I live in San Antonio.
Oh, then you need to get Arturo's card because he lives in San Antonio, and he's a certified wound specialist, and he's the product rep.
Okay.
And he can help make sure you're using the right products.
Okay.
And he's a great resource to have down here.
Okay.
He's a very smart guy. Don't tell him I said that.
Thank you so much.
You're welcome.
Learned a lot.
Thank you. I'm glad you did.
Thank you very much.
I don't look at them every 3 days.
unfold.